All right, let's go ahead and get started. Once again, welcome everybody to the PCBH SIG general meeting for the month of August. A few items on our agenda today. We'll just briefly go over some announcements, and then we'll introduce our guest speakers for today. And they will take over with a case discussion presentation, and then we'll have some closing remarks. So announcements. Does anybody here have any job announcements that they are wanting to make? Anybody hiring? Or anybody want to share any learning opportunities or any other type of announcement or shout out that you all want to make?
I'm hiring.
All right.
We have a brand new position that just opened in New York State. It's in Westchester County as an integrated behavioral health clinician, or BHC, in a practice that has not historically had one. So it is the first time we're bringing someone on site to support quite a number of doctors to begin with, about 15 physicians. So if anyone's interested or knows anyone, please reach out to me.
Thank you. And if you could probably just enter your email in the chat for folks to back channel you, that would be great. Anybody else have any announcements for job opportunities or learning opportunities?
I'm new here. I was referred here by our head psychologist at Aspire Indiana Health. So I'm not quite sure of the audience I have right now, and I apologize. We do have several behavioral health consultant openings at Aspire Indiana Health in a number of different clinics, supporting up to 4 to 5 providers, both psych NPs and primary care. So I don't know if that is relevant, but I'd be happy to send my email on the chat as well.
Very relevant, and thank you for sharing.
Great. I will do that.
Anybody else? All right. So just as a reminder, we have 2 more meetings after today's meeting. Our next meeting will be in person at the CFHA conference in San Antonio, the Friday morning of the conference. I believe it's scheduled to be at 7 a.m. And then we have our final meeting on December 4th. We have a great panel of speakers. So I hope that you all will be able to join us for our next meetings as well. And another announcement, we are more than halfway through the year now, so that means that the PCBH SIG will be looking to fill some very important leadership positions. So we will be looking for a co-chair. This is a 2-year commitment. An early career representative. This is a 1-year commitment, and a student representative. This is also a 1-year commitment. We will be making an official call out on the SIG for people who are interested. And then there will be an election process. So if you know of anybody that you would like to nominate, please keep an eye out. If you also have any questions about what these leadership positions are all about, what the type of work hours or commitments, please back channel us. You can back channel any one of us on the in the SIG leadership positions right now, and we are more than happy to answer any questions that you have. All right, as always, we have a mentorship connector program. So if you are in need of a mentor, or if you are interested in mentoring, you can always scan this QR code. It will take you to a Google form to fill out. These links are also live on our website, the PCBH SIG website, under the CFHA website. So you can always access this if you need a mentor or would like to mentor. And then last announcement before I introduce our speakers, we're always open to feedback for programming for the SIG. So if you want to give us some ideas about topics or recommend guest speakers, you're more than welcome to submit some feedback, and you can access this survey by scanning the QR code. All right, so next I'm going to introduce our speakers for today, and then they will take over. So we have today Dr. Stookey, Dr. Nikol, and Dr. Hale. Dr. Stookey received her PhD in clinical psychology from Temple University and completed her postdoctoral fellowship in geropsychology at the Philadelphia Geriatric Center. She's been a practicing licensed psychologist for 27 years. She has exclusively worked in integrated care using the PCBH model for over 10 years, including for the Air Force BHOP program, in an FQHC, and now in a value-based care model. She is currently the National BHS Training Lead for One Medical Senior Health Division. Dr. Nikol is the Director of Behavioral Health at Summit Health and currently oversees a staff of 50-plus clinicians, social workers, care navigators, providing face-to-face or virtual cognitive behavioral therapy or integrated care in New York and New Jersey. She has clinical expertise in depression, anxiety, trauma, adjustment to various health conditions, grief, obesity, and weight management, relationship conflicts, work issues, stress management, and integrated care. She also serves on the credentialing committee for the Academy of Cognitive and Behavioral Therapies. Dr. Nikol has a DBH from Arizona State University, an MSW from Rutgers University, and a master's in organizational psychology from Columbia University. And Dr. Hale is a licensed psychologist and primary care behavioral health consultant for Riverview Health in Hamilton County, Indiana. Clinical areas of interest include stress-related illnesses, lifestyle modification, chronic pain, smoking cessation, behavioral sleep medicine, chronic disease management, and trauma. She is also passionate about addressing biases in healthcare and reducing health disparities. She uses primarily ACT-FACT techniques to help patients build more adaptive habits and connect with their values. She has previously served on the PCBH SIG leadership team twice and currently serves on her organization's Provider Leadership Council. So let's give a warm welcome to our speakers today. I'm going to stop sharing the screen because they have some slides to also share with us.
All right, I'm going to try to share my screen here. Let's see how it goes. All right, is everyone able to see that? And I can put it into presentation mode. Is that visible to everyone?
Yes.
Okay. All right, we can start with some introductions. Rosie.
You're muted. Sorry about that. I'm Rosie. I'm a clinical psychologist at Riverview Health, just north of Indianapolis. I actually did my internship at Aspire, which got mentioned earlier, so connection there. I work in 2 of our primary care clinics. Like Gabby mentioned, I mostly use ACT and motivational interviewing techniques. And I'm really excited to be here and talk about body image and weight concerns. I think that's a really important topic that the medical model is not my favorite in terms of how it contributes possibly to weight bias and stigma. So we'll definitely be talking about that today.
So I work at Summit Health. I've been at Summit Health now for over 16 years. I was the first clinician hired in the newly created Behavioral Health Center and then went on to get certified in CBT. And to date, that therapy center still does exclusively CBT work, and I oversee that now. In addition, I started the IBH team back in 2015, and we currently do both virtual and in-person support of about 250 primary care doctors. We're also in oncology and in pediatrics. And so my approach to obesity and weight management tends to be from a CBT lens, and I'll talk a little bit more about that today. Sarah?
Good morning or afternoon. I'm in Arizona, so I'm a little confused in terms of times always. I am the BHS training lead for One Medical Seniors, which is a division of Amazon One Medical. I work specifically and exclusively with older adults. And if anyone is interested in geriatric psychology, please let me know, because there are not enough of us in this world. And it is weight management issues are something that we frequently see coming up as people age, because not only do we have the hormonal changes for women, but we also have changes in lifestyle that lead to some more sedentary lifestyle. So we are dealing with this a lot, and also with patients who can't always do the type of exercise that's often recommended because of their limitations and health conditions. So it's a unique population to work with in terms of working with the weight management issues.
Okay, and so what we thought we'd do for you today is each give a case example from the settings that we work in, and then kind of hopefully get some audience participation, whether it be in the chat or you want to unmic yourself to tell us a little bit about your thoughts. And then we'll also share what we would do as the treating provider, as well as get the other two clinicians working with us today to tell us a little bit about how their approach might be different. And so, Rosie, you're up first.
All right, I remembered to unmute this time. All right, so I might not look like I'm looking at the screen, but I'm reading off of my own screen, so bear with me. My case is Jill. She's a 27-year-old cisgender female referred to speak with our BHC about her primary care provider's concern about her weight. Her PCP expressed concern that her BMI, which is 38, and encouraged Jill to consider working on weight loss. She expresses some embarrassment, kind of being upset that her PCP focused on her weight and brought that to her attention. She's not super optimistic about meeting with a BHC about it. She shared that she struggled with insecurity about having a larger body since she was a child. She experienced some bullying in elementary school and had some disordered eating behaviors in high school, some restricting and some binging. She continues to have poor body image, frequently comparing herself to the body of others. She describes herself as an emotional eater, using food to both cope with stress and reward herself. She tends to eat more and choose high calorie dense foods, mostly in the evenings. And she's previously tried several different diets, but not found any of them to be especially helpful for weight loss, and found it difficult to maintain those eating habits for more than a couple of weeks. She doesn't engage in any regular physical activity. She does have a history of anxiety and depressive symptoms, which she states have been well managed with 20 milligrams of Lexapro for the last few years. In other contexts, she's a full-time graduate student working towards her master's of library science. She works part-time at a bookstore about 20 hours per week. She has a roommate who's a close friend of hers. She's single. She's good relationships with her family, which includes her brother who's 22, and her parents. They live less than an hour away. She likes to read, draw, and listen to music. Sleep is good, no substance use concerns, no chronic pain issues. She's had a little bit of mildly elevated blood pressure a handful of times, but no diagnosis of hypertension and no other health concerns. So imagining that this is our first visit, we gather all of this information. I'd love to hear from you all about thoughts, where you might start, contextual pieces of information that kind of stick out to you. I'd love to open this up.
Megan, you've got a hand up.
Sorry, that was totally accidental, but I will let somebody else start. It looks like Jessica's got her hand up.
I am learning. So I have been, I'm the director of behavioral health for the FQHC at Aspire since last November. It's a brand new role. And we've had BHC interns and BHCs, as Rosie might have said in the past, but like this is like the first time we're intentionally looking at this. And so what I've built, kind of how we fashioned our first BHC consult, is the contextual interview. Beachy and Bowman has really informed a lot of what I've crafted in terms of training. So I would probably start with just getting contextual information about their supports and where they're living or how she's living now. There's a lot of that in piece, but just really drilling down on certain things and really talking to her about what she would like to focus on and what she sees as better health for herself, and not necessarily starting at all the time with where the provider thinks they should start, but you have to start with where they're at and what they want to do, the change they want to make to become healthier. So I'd probably just get that contextual information, both about her life, if I needed more, and then also about the actual behaviors that come out of that contextual interview. I hope that makes sense.
Yeah, and I love what you're saying about kind of clarifying her goals, because I agree, especially when a consult is like weight management or weight loss, I'm always like, let's go ahead and say that's not going to be our goal necessarily, and talk with the patient about what in terms of their health is most important to them, especially since, as we gathered, like she's not really excited about the idea of talking about her weight. So why push that and kind of add to her experience of stigma? But yeah, find what else.
Even when I'm marking it up for the huddle in the morning, I don't even put weight management. I put healthy habits. If there's a BMI identified, I put healthy habits. I don't even put like weight management or diet. I just put that kind of overall.
Love it. I do healthy lifestyle modification. Same thing.
Yeah.
Other thoughts? Okay. So
I have one more thought.
Yeah.
Aren't you glad I'm here? I'm like, oh,
Definitely.
I would also want to know if there were any, and I can't remember in the actual vignette what it said, but if there's any medical diagnoses related to being overweight to focus on, and just talking about what she could improve to improve that diagnosis or improve management of that diagnosis, whether it's hypertension or diabetes. Those pieces would also be something I'd want to start with.
Yeah, if there's actually a health condition, because not obesity, that we can highlight. Yes. With her, she did not have any. She had a couple instances of elevated blood pressure, but no diagnosis of hypertension. Still something that we could talk about, like, hey, noticed your blood pressure had been a little up a couple of times. Here's some things that we can do to help improve that. So yep, that's another thing we could do. So separate from like maybe questions we have about her context, switching gears more to like interventions, are there any strategies or approaches that people come to mind? If this was a patient that you had met for the first time, where would your mind go first?
This is probably something that I would ask about a little bit, sort of in more of the info gathering, and then also maybe utilize intervention-wise if it was a key area. For you mentioned the sort of low body image and frequently comparing herself to others. So I would also be curious. I practice from a pretty strong ACT lens as well. So I would be curious about kind of like just what her mind is saying to her, how tightly she's holding on to those thoughts, if they're impacting her choices or her life behaviors at all, and maybe working with some acceptance and diffusion strategies if those things are impacting her in ways that she's concerned about.
Yeah, I love it. What are the messages that your mind is telling you about your body size, about your eating habits? That those are often more problematic than the eating habits themselves. What's going on there. So definitely that's where my mind tends to go to. Other thoughts? Because I'd love to hear people that like come up with something totally different than how I might approach this.
Any of our more CBT folks in the audience have a perspective that might sort of broaden our scope a little bit here?
Hi, everybody. My name's Ashley. I work over in integrated primary care at Mayo Clinic. And when I work with patients on trying to lose weight or adjust their kind of health behaviors overall, well, I tend to approach it almost from a harm reduction lens and talk about how, there are going to be times where it's okay to go out and eat some of those things that you really like. And one of the things that we can really fall into if we have that inner critic is we start to beat ourselves up for it. And so to really be mindful of, okay, let's look at kind of that 80-20 rule. And if you are going to go out and you're going to go get pizza with your friends, or you're going to go like get beer with your friends, maybe really focus on what you're doing before. Eat something healthy, get some exercise, and try to find that balance so you allow yourself a little bit of grace and show yourself some compassion while you're trying to make these changes. Because if you go all in, there's a really big chance that you're going to set yourself up for failure. And that inner critic is going to come in and just kind of derail everything. So with the people that I've worked with, that's been a pretty successful strategy.
Yeah, I love it. I moderation, right? Like the moment we say, oh, I'm not allowed to ever have that, or I can't do that, we kind of set ourselves up for wanting it even more, beating ourselves up when we inevitably do have the thing that we enjoy eating, because of course we're going to at some point.
Sure.
So yeah, passion is great.
Yeah, and really looking at, if you are going to go out and have it, how do you modify it? So are you going to just kind of take one piece of pizza and put that on your plate and make sure you're not taking any more? I've talked to people about like going to ball games and things where you order an ice cream and they give you 5 scoops of ice cream. So
Sure.
just like ask for 1 scoop, or if you need to, take a couple bites and throw it away, and just really reimagining how you're going to approach that food. So you're still getting to engage with the things that you enjoy, but not, like you said, having to completely avoid it, which can lead to some of those relapses in that behavior.
Yeah, it kind of sounds like mindful eating in a
Yeah.
way. I always tell people, like, if you're gonna eat that cookie, like do it on purpose. So
Yeah.
this is a conscious choice I'm making to eat this food, rather than a response to an emotion or an automatic habit.
Mhm.
Like I'm choosing what I want to put in my body, whatever that is.
One of the nurse practitioners I work with gave someone this feedback of, we get these cues for emotional eating when you get like that automatic hit that I need something sweet or I need something salty.
Mhm.
Instead of it building up over time, you feel frustrated. You're like, man, I need a cookie. And so just being able to take that step back and, like you said, be mindful of that, of like, okay, am I wanting this now because I'm hungry? Am I wanting this because I'm responding to an emotion? And that's been really helpful with our patients as well.
Yeah. So like with this case in particular, I think that might be a helpful strategy, because she mentioned some emotional eating. There is some anxiety, depression, even though it's kind of well managed right now. But yeah, learning to kind of tune into her own hunger cues. Why am I feeling this way? What do I want to do about it? Yep, those are some good thoughts too.
Jessica?
Also, something that came to mind is just more of a brief solution-focused, strength-based approach. Tell me about a time where you were more active, or where you were, feeling healthier in general. Tell me about a time that you were doing that, and looking if there was a time where she felt like she was able to either be active or she was feeling healthier. And it doesn't even have to be like, oh, I was eating less or I was eating healthier, but I just felt healthier when I was, in college. Or, well, what was different about that time? Tell me about that. And really trying to identify some personal strengths, since it seems the self-esteem is really in the toilet right now. And seeing if you can get anything that she might want to put back in place than she used to, and helping her identify, or the miracle question, like if you woke up and you felt healthier tomorrow, what would be different? So that she can come up with the answer, and we're not necessarily the one saying, well, if you did this, maybe, and of course there's an element of that too. But if she said, well, I would just have more energy, what do you think is in the way of you having that energy right now? Probably, a donut that I ate, or whatever that is in the morning. What would help you have more energy in the morning, so that you can maybe try and get that from her? It'll be much more impactful if she has the answer.
Yeah, I love solution focus, and my brain never goes there automatically. But if I'm like really thinking about it, I can kind of get my brain to go there. I think those are great strategies. Yeah. Anything else before I kind of talk about a few points of that came to mind for me, though, that I came up with? All right, so I'll kind of share my thoughts, and then our other panelists will share theirs as well. So for me, that stigma piece kind of comes out loud and clear. So I would want to explore with her a little bit about her experiences with providers, highlighting her weight, what that means to her, how those have impacted her health behaviors. We know that actually weight stigma is more harmful for our patients than having a larger body size. That perhaps she's actually emotional eating because of how she felt after going to the doctor's office and how they made her feel. So wanting to explore that with her, and maybe provide some education on weight stigma, kind of normalize her experience of being uncomfortable with how that conversation's been had with previous providers. I'd want to explore her thoughts and feelings about her body size. So kind of that cognitive diffusion that was brought up earlier. Might even do some perspective taking, but just kind of noticing what thoughts she has around her body size, around her eating habits, developing some acceptance, using some self-compassion to kind of reduce the importance placed on her body size or that number on the scale, and trying to shift more of a focus to her health. So whatever your body wants to be size-wise, when you are taking good care of it, that's more important to us than anything else. Definitely would maybe address some stress management techniques and just some basic coping skills, since you mentioned emotional eating. So what are some other things we can do when we're feeling that distress? Working on maybe identifying some of her triggers, altering her environment. So if she's mentioned that she tends to eat a bit more in the evenings, is there a different room maybe that's not right next to the kitchen that we could relax in at the end of the day, where maybe you're not going to be thinking about food quite so much? Having healthy foods just readily available in the home, that's kind of a go-to for me. When the less healthy foods are right there next to you, you're going to snack on those. But if you have other foods that you enjoy that are just as readily available, that can be really helpful. I mentioned in the vignette that she uses food to reward herself. So I don't want to take away her reward, the thing that she does when she has a good day or works hard on something. So we'd come up with some other alternatives. How else can you still give yourself that kudos without using food? And then some psychoeducation on the importance of building healthy habits that are sustainable rather than those limiting diets. She said they didn't work for her. They don't tend to work for most people. So the importance is, what is the habits that I can see myself doing long term, more of that lifestyle shift rather than eliminating certain food groups or restricting myself to a point where, yeah, I only can sustain that for a couple of weeks because it's really not going to work for me in my big picture. So those are my thoughts, and then we can kind of hear from the other panelists who have a different approach.
Sarah, you want to go first?
Sure. So for this one, there were a couple of things that stood out to me. So she's very young. And one of the things that I would want to look at in terms of her body image is, what does her social media look like? Because is she following people who are have very thin body types, maybe unrealistic for her? And what does she think about finding ways to engage in social media that gives her a healthier body image and shows her people who are healthy doing some of the things that she is interested in? Along those same lines is looking at what are the things that she wants to do that she feels like she isn't doing because of her weight? What are those goals? And maybe helping her to see, it's not why not start now? There's no reason that you have to wait to do whatever. If you want to start running or start doing something, start it now where you are, because it's not going to be any easier to start it later. It's just, they're waiting for the right moment, and the right moment being the weight loss can be putting things off and not at all contributing to her overall happiness. And really just seeing, if her health is getting in the way of her goals for some reason, then really focusing on reaching that goal, and the health piece of it will be a part of it on the way. But since she's not somebody who feels like her weight is the issue, which is fine, I don't have a problem with that. I think it is a very individual thing. But okay, so if your goal is this, then how will being healthy help you to reach that?
And I would just add, again, getting in touch with the thoughts a little bit more. I'm intuiting from the case write-up, that she might have thoughts around, not having self-control, or no one likes me, or I'm bad for some reason. Also, to that point, if she does not have problems with her body type or size, what are some of her automatic thoughts about the doctors? Because clearly she doesn't feel like her providers are on her side. So talking a little bit more about those, and really trying to designate what's the thought about all of this that upsets her the most. Does it have anything to do with her body size, or does it actually have to do with some other things, like what she's seeing on social media, or like the way her provider speaks with her? Get in touch with some of those, and then from there kind of craft a plan to move forward in addressing some of that. Also, had a note to myself about food being reward, and kind of educating that in and of itself is a thought. If I come home and I've had a tough day and I say, okay, I deserve a drink, or I deserve a chocolate bar. That is a thought. It's not a fact. So how can we address talking back to that thought a little bit to give her some choice there, as opposed to it being necessarily a rule that she follows when she's feeling bad? Okay, any other questions about Rosie's case before we move on? All right, well, I've got Dennis, and I also will be looking down so that I can read this to you. He is a 47-year-old cisgender African-American married male referred by his PCP to the BHC for, in quotes, weight management after becoming teary-eyed during his physical. He has high cholesterol and was put on a statin 6 months ago. He also has hypertension that is well controlled with a beta blocker, and asthma that he uses a steroid inhaler and a rescue inhaler for. His A1C has been creeping up over the last couple of years. Currently pre-diabetic with a score of 6.1. His weight is the heaviest that this provider has seen at 264, a BMI of 37. His father died of complications from diabetes and actually had 2 toes amputated before his death. The PCP is prescribing metformin for the first time, wants him to meet with me to talk a little bit about healthy habits and how to potentially adjust his diet accordingly. Also, the doctor would like to see him try some of these basics before thinking of something like a GLP-1, Ozempic. He's worried he's doomed to repeat his father's path, because this is, of course, what he's seen, and feels very helpless, is angry that another medication is being added, also increasing his expenses. He does travel a lot for work, and admits to eating lots of fast food on the go several times a week. Sometimes he's eating lunch in his car. He shares that he and his wife, enjoy food together. She also is overweight, but in his family of origin, food is love. And most of the time, food is involved in celebrations. He has a cousin who recently was successful using Noom. He also states he doesn't exercise due to his travel schedule, and wants to spend time with his 2 teenage children on the evening or the weekends, and not necessarily be exercising. He'd rather be at his son's football games or his daughter's dance competitions as schedule allows. And so he says he's tried to make changes to be healthier, right? He has a salad every now and again. He's cut back on regular soda and is drinking diet soda. He tries to park his car a little bit further from the office. He can be successful for a few days, and then he has, quote, a bad food, and sabotages himself by saying things like, I messed up and I ruined it. I might as well start over again next week. I have no time for today for healthy eating. I've never been successful at this, so I might as well just take the meds that they're throwing at me. No substance abuse, no apparent mental health history to date. Although during the moment of the hallway handoff, he's very upset and says that his conversation with his doctor made him feel really sad and scared. So when you think about Dennis, what thoughts do you have about how you might conceptualize this, or where you'd like to start?
I feel like he needs a dose of reality testing a little bit, because his focus is on spending time with his kids, which you can admire. But at the same time, he has to understand that continuing this lifestyle, the reality is he might not be there in the future for his children. So starting to set some small attainable goals, I think will be essential. So it's kind of a more gestalt approach, but at the same time, he has to understand that his actions are detrimental for his future.
I love that. It's also a little bit of a values perspective from acceptance and commitment of really saying, wow, you really seem to value family, and a little bit of like the motivational interviewing, of like, on one hand, I'm hearing you say that family is really important to you, but on the other hand, I'm hearing that you've got some health issues going on that might impact your ability to be here. So I love that. Great. Jessica.
Mine was also kind of around the family piece. I'm a marriage and family therapist license. And so my training is that piece, and using the family values as a strength for him too, of well, let's get the family on board instead of trying, cooking and trying new foods. Well, you can still do that. It can be healthier, and meal prep can be something you do with your wife together. And you guys can empower yourselves by looking at an exercise routine. Maybe that you start doing a nightly walk together, if time with the family, or a morning walk together. And then I'm thinking of the multi-generational approach too. He saw his father do this. How can you start a more active lifestyle and involve your children? If that's something you want to do together at night, okay, they have football and they have choir. And I know I have 4 children, so I understand that a lot of it is around them, but maybe you do something active with each child, at least a few times a week together. And so you're also showing them that activity is important to the family and health, and you're also able to spend that time together. So really maybe revisiting, how am I spending my time with my family? And it can all be very active and healthy together, and we can redefine how we're spending that time together. So that was one thing I thought, just the family value was really important. It looked like to him as.
Yeah, and a lot of brainstorming, right, about what kinds of things in life can you do that don't necessarily involve unhealthy behaviors. Reminds me a lot of when you're working with a substance user in terms of thinking about their social life and how they might do different things than always spending it at a bar or drinking at a sporting event, and really moving things out to connect with your family in different ways that encourage healthy behaviors of all of the members, not even just yourself. Great idea. Anything else? Okay, I notice it's already 1:40, so I'm going to go ahead and jump in, and then we can hear from Rosie and Sarah. Obviously looking at advantages of making this a priority. If you're interested in a bit more of a CBT directed model for weight loss, the Beck Institute has trainings. That's where I was trained. And Judy Beck has written several books about using CBT, and she never recommends a particular diet or a particular nutritional scheme. It's all about how do you use the thoughts to really support whatever it is that you're trying to achieve, changing them so that they support you rather than hinder you. And so the biggest exercise that patients are given at first is figuring out their why, right? What are the advantages that they see in using any sort of tools to lose weight or get healthier, right? So as mentioned, things like, I want to be here for my family. And so once you have that list, you encourage people to either put it on their phone, put Post-its all over their house, and when they're tempted to make a not so good decision, remind themselves of why they're even trying to do this in the first place, right? And a lot of times that can increase motivation in the moment and give them an opportunity to kind of walk away maybe from the choice that wouldn't have been quite as good. So introducing this kind of CBT model and highlighting the fact that thoughts are really critical in any sort of behavior change that we want to make. And create verbiage to reframe some of these thoughts. Particularly with Dennis, I would be looking for what is the most damaging thought, right? So some of the things that I had written down, I can't eat healthy on the go. In order to enjoy time together, food is always involved. I messed up. I'll just start again on Monday, right? So highlighting that these are actually thoughts that get in the way of the good behaviors, and how can we start to maybe pick one today that is the most dangerous or damaging and talk back to it a little bit. Consider maybe some very simple and small ways to engage exercise in his life. So really celebrating the fact that he's trying to park his car further away from the office. What are some other things he could do like that? Could he take a lap around the office at work? Could he, at the hotel he's staying at, find out if there's a gym and he could walk on the treadmill? Are there little things that could help and make a big difference, both for him or maybe, like we've said, with his family members? If he's not food tracking at all, I might just encourage that to get some data collection, right? He may have no idea that when he is eating McDonald's in his car at lunchtime, that he's actually consuming his full calorie allotment for the day, right? So just helping him gather some information to see where he's at. Also giving credit. One of the things that people who are trying to make behavior changes do is they beat themselves up potentially for the 1 or 2 things they didn't do or they did poorly on a particular day, as opposed to really highlighting the little things that they did through the day that are critical, like, there was a party in my workplace and I decided to say no to the cake that day, or I went at lunchtime and I did, 2 laps around the office. I took the long way to meet with somebody and I walked the staircase instead, right? Noticing those things and really celebrating them. Exactly what you guys said, discuss ideas for non-food related fun with family, and also brainstorming ideas for good choices while traveling, right? So oftentimes we believe we can't be healthy when traveling, but what are some things that could be done? Are there some things he might want to pack with him? Will he have a fridge and a microwave in the room? What are the restaurants nearby that might be better choices than others? And then finally, kind of gauging what his knowledge is. And if I feel that he is really giving me information that tells me he doesn't really quite know about eating healthy, maybe he's never met with a nutritionist. So at Summit, we do have nutritionists that are part of an option for us to refer to. So if I feel that the patient's knowledge is lacking, I may offer that up if they're looking for some tips. And I always remind them, I'm not going to suggest what to eat or how to eat, or give them a diet plan. We want to have the professionals kind of help in that regard if they're available. Sarah or Rosie, thoughts?
I can go quickly because I want to be mindful of the time. I had a lot of the same things have been discussed either by Liz or by other participants today, but coming from an ACT and values-based lens, just things that I would highlight were doing things with his family that are important to him, hopefully maybe even getting his family on board with some of the changes that he's wanting to make. It's definitely easier if we can all eat the same way as a family, or we all go for a walk together. And then rather than doing like cognitive challenging or reframing, I tend to focus more on diffusion. So maybe we would come up with a name for those unhelpful thoughts. That's my stuck mind talking, and just learning a different way to talk to those thoughts and kind of letting them go rather than giving them too much space in his mind.
And just briefly from me, one of the important things I think here is to look at right now, it looks like a lot of his motivation is from a fear basis. And that can be okay in the short term, but in the long term, that doesn't tend to be very helpful, because if what you fear doesn't happen, then it loses its power. Regardless of what you're doing, if you're not doing those things. So I think really just finding that internal motivation of what he wants, as opposed to avoiding the early death, the disease processes and so forth, is going to be important for him as he moves through this process.
Okay, any more comments on Dennis before we move on? All right, Sarah, take it away.
All right. So since I am from a geriatric perspective, I'm going to talk about a typical geriatric patient who might come in. So Maggie's a 66-year-old married Hispanic woman. She retired after 30 years in the public school system, where she was a teacher, then a principal. She's always had a few extra pounds, but since entering menopause, she's gained 50 pounds in 12 years. She's been on multiple diets in the past. She's done everything that she can think of to try to lose this. She's had success in some and then gains back. And she does have some habits in terms of her exercise. She goes to a water aerobics class. She walks with a group of friends. She has a healthy diet, but has a few extra treats now and then, and she doesn't understand why she can't lose weight right now. So she doesn't have any major chronic conditions other than the weight issue that has been brought up. Her blood pressure and her A1C are starting to creep up. And so she and her PCP think that taking a more proactive approach by managing her weight would help to keep her healthy. So what are some of the things, or what are some of the ways that you might approach this with Maggie?
Can you go back to the first slide? Sarah, I'm so sorry.
Let's see if I can.
Liz is in charge.
I got distracted. I want to see the first part of it.
66-year-old Hispanic woman who retired last year after 30 years in the public school system. She describes that she's always had a few extra pounds, but since entering menopause 12 years ago, she's gained 50 pounds. So, and again, in the interest of time, I'll just talk a little bit about what my approach would be. And anybody who wants to chime in can certainly say something as well. So first, for me, part of the issue is she's been on all of these restrictive diets in the past. Every one of those has you either giving up something or counting calories or something. And that can be something that can cause, you know, what little t trauma in terms of what's sometimes called diet trauma. You get into this idea of, oh my God, I have to do this again. This is going to be terrible. I have to give up this, 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 and this. So that could be impacting how she is looking at weight management and her fears regarding it. And it can also impact how well she does, because she may not be able to follow a plan like that for very long because of those experiences that she's had in the past that they don't work long term, which is exactly the case. I would also want to talk about some of the hormonal changes that have happened to her since menopause. And this is a really hot topic right now, which I think is important because we don't have enough research on it. But really talking about how, yes, it actually does change. The hormonal changes that you're going through are going to impact your weight. And that is also something that could be impacting your behavior. If you are feeling more emotional and you're not really able to express that well, or you don't feel comfortable expressing it with people who you need to, then what are you doing with that? Are you an emotional eater? I would also want to look at what those extra treats really look like. You know, and this is where I would probably say, let's do a food journal. And I always tell people the journal is not for me. You don't have to share it with me. It's really for you to be more mindful of what's going on. Because you can tell me today, oh yeah, I ate out a couple of times and I did okay. But if you're writing it down that day, you're really looking at what did I actually eat and how many times did I actually have a piece of chocolate or a few chips or grab a cookie or whatever. So really just to have her be more mindful and also to give good starting points. I would, of course, address all the sleep and alcohol, caffeine, and those things to see what's going on. But I often start with patients in terms of one small change. And I tell patients all the time, if you are losing even just a quarter of a pound a week with that one small change, then let's not change anything else, because we want that habit really honed in before we add another one. So if she's just journaling her food and finds, wow, I'm really paying attention and this is helping, great. Come back to me when you plateau. Let's talk about what's happening then. That way she's not trying to, you know, have all the, I call it spinning plates. If, you know, if you're spinning this plate, you have to go over here and spin this one and this one, and then eventually some of them start falling. Let's just focus on one plate at a time. Any other thoughts, Liz or Rosie?
Rosie, go ahead.
Sure. So one area that I would address, because I do see quite a few geriatric patients as well in my population. And sometimes when we're dealing with postmenopause, like weight loss is really, really difficult. And I can't even say that that's going to be possible for the patient. They might be eating everything their doctor is asking them to eat, and they're exercising, you know, 30 minutes a day, 5 days a week, and that weight just isn't coming off. So in that case, I'm going to focus more on how does your body feel? Because a number of my patients will say, well, I'm sleeping better, I have more energy, but I'm the same size. Well, that's great, right? You're sleeping better, you're feeling better, you feel stronger. So I would just want to reframe kind of what our goals are for change, and it might not necessarily be weight loss, but how does your body feel as we work on these healthy changes?
Yeah, I would definitely validate her experience during menopause. You know, a lot of the reading I've been doing lately talks also about how different your food choices need to be after menopause, as well as how your exercise regimen needs to change. So I would, of course, commend all of the exercise that she's doing, but you know, all of the research these days is saying that, you know, weightlifting is critical for women that are in menopause. You know, that potentially doing a lot of cardio is actually damaging some of their efforts. And in addition to that, lots of protein. They need to eat more protein. So again, around the food journal, I might be saying, let's find out, you know, what your macros look like. And if something seems to be off, again, maybe we'd refer you to a nutritionist to talk about some of these a little bit more. Or if your system has a menopause certified doctor, or just someone on the OBGYN staff that you feel is really competent in this area, you might make an internal referral. And then also I was thinking of some of the thoughts that she might have said during this interview, like, I always fail, nothing works, this is pointless, and see what we could do to kind of get under that and give a little more credit for all of the effort that she is making. Any further questions, discussions, thoughts?
Awesome. Well, thank you all to our panelists and all of our attendees today. Really great conversation, tons of good, really, I think, practical take-home tips. So I just wanted to kind of share out one final thing. I'm actually prepping a discussion among our postdoctoral interns right now from UpToDate, which is a great point of care resource if anybody has access to that. And the topic for today is obesity. So I was just really kind of in the thick of what UpToDate has to say about this, and it's really consistent with what everyone was sharing today, which is great. And really of note, they're talking about how dietary changes, movement, physical activity changes, and behavior modification are all key to long-term weight loss maintenance. And the single biggest predictor of success in weight management areas is patient adherence. So when we're thinking about all of these different strategies, and this was really clear in terms of what everyone was sharing, I think the biggest take home is just what is your patient interested in doing, what's important to them, what are they willing and able to do, really tailoring it to them specifically. And there were so many great thoughts shared about that today. So I'm going to go ahead and share my screen real quick. We have just one final slide for kind of closing remarks. So this recording will be posted. There's actually an updated link, so I apologize, this is an incorrect link, but Hannah posted the accurate, up-to-date link in the chat box, so you can see that if you are interested in reviewing this afterwards. And then just one final plug, our next meeting date is going to be on October the 25th. That'll be at the conference, and I believe that there is an error on the CFHA, like this conference schedule right now for when the SIG social is. It says it's on Friday. It's actually going to be on Thursday. So that's just a time, no specific topic. That's just like a hangout time. So we just all get together, and that'll be from 7 to 9 p.m. On Thursday of the conference, and we will announce that location shortly. We're still trying to decide what's going to be a good place to gather for that. So again, thank you so much for joining us today. If there's any final questions, comments, things that people want to share out or ask, we've got a few minutes left, or if folks need to move on to the rest of their day, that's good too.
I just wanted to say I've appreciated all of this, and we're seeing such an increase of Ozempic prescribing, and I think that there's a place for that drug, but I see even staff like really gravitating to that as the answer. And it's really discouraging to me because I had a staff saying, "Oh, I'm taking Ozempic," as she has like this huge bottle of Coca-Cola Classic, and so just how I've almost thought like that should be actually a comprehensive treatment approach. If you're getting Ozempic, you're also getting just BHC, no question. So if there's ever any topic on that, I would love to.
I would also shout out for everyone here, that would be an incredible pathway to implement at the clinics that you're at. It would be fairly straightforward if you can kind of get everybody on board with the idea of anybody who's being initially prescribed any of these, it's the acronym, the agonist or whatever. Yeah, so any of these weight loss medications that automatically has to come along with a BHC referral. We do this for things like chronic pain meds as well. I think I agree with that. We're seeing a ton of it here as well. And I think really important that we surround it with other kinds of support. Okay, well, we'll hang out here for a couple extra minutes. If folks need to leave, have a great rest of your day, or if there are additional questions or comments, can shout them out or drop them in the chat box.